I'm Dr. Whitfield, and I need you to stop what you're doing for the next 15 minutes. Raise your hand if you take ibuprofen for joint pain, knee pain, hip pain, that stiff lower back in the morning. Ibuprofen. It's in your medicine cabinet right now. Maybe it's on your nightstand. Maybe you took one this morning without even thinking about it. Here's what I need you to understand. After 65, every single tablet is silently scarring your kidney tissue in a way that cannot be reversed. Not slowing down kidney function, not mildly irritating it, scarring it permanently. And here's the part that makes me genuinely frustrated. Your GP might still be handing out prescriptions for it, or at least not telling you to stop. I'm not here to alarm you unnecessarily. I've been in medicine long enough to know that fear without information is useless. So this video is going to give you the full picture. What ibuprofen is actually doing inside your kidneys after 65. Why age is the specific variable that changes everything. And what you can replace it with. Because I'm not going to tell you to just suffer through joint pain. There's a protocol I've been recommending to patients that actually works, and we're going to walk through it together. Let's start with the basics, because I think a lot of people genuinely don't know how ibuprofen works. Not on the pain, on the kidney. Ibuprofen belongs to a class of drugs called NSAIDs, non-steroidal anti-inflammatory drugs. And the way they reduce inflammation and pain is by blocking certain enzymes in the body called COX enzymes. COX-1 and COX-2. These enzymes produce compounds called prostaglandins, which are essentially the body's local signaling molecules for inflammation and pain. Block the COX enzymes, you reduce the prostaglandins, you reduce the pain. Simple enough. But here's the thing. Those same prostaglandins that cause inflammation and pain, they also do something else entirely. They regulate blood flow to the kidneys. Specifically, they dilate, they widen the tiny blood vessels that supply blood to the kidney tissue, the glomeruli, the filtering units. When ibuprofen blocks prostaglandins, it's not just blocking pain signals, it's also constricting those blood vessels, reducing blood flow to the kidneys every single time you take it. In a young, healthy person with fully functioning kidneys, this effect is usually temporary and the kidneys compensate. The body adapts. There's enough reserve, enough redundancy in the system that it manages. But at 65 and beyond, the picture is completely different. Here's what happens to kidneys as we age. It's not dramatic. It happens slowly, which is exactly why it's so dangerous. By the time most people are 65, they've already lost somewhere between 25 and 40% of their kidney function, just from aging alone, not from disease, not from anything they did wrong, just time. The kidneys shrink slightly. The number of functioning nephrons, those tiny filtering units, decreases. The blood vessels in the kidney become less elastic, less responsive. The whole system becomes more fragile and less adaptable. So when ibuprofen constricts blood flow to kidneys that are already operating on reduced capacity, kidneys that have already lost a quarter to nearly half of their functional reserve, the impact is not the same as it is in a 30-year-old. Not even close. And this is where it gets important, because the damage isn't just acute. It's not just your kidneys are working harder today. Repeated constriction of those already compromised blood vessels leads to something called ischemic nephropathy. Micro injuries to the tissue, small areas of scarring, and kidney tissue doesn't regenerate. It doesn't grow back. Once it's scarred, that's it. That filtering capacity is gone. I want to say that again because I think it doesn't quite land the first time. Kidney tissue that is scarred does not recover. You don't get it back with rest. You don't get it back with hydration. You don't get it back at all. There was an older gentleman I saw years ago. He came to me for something completely unrelated, hypertension follow-up. And we ran routine blood work. His creatinine levels, which is a marker we use to assess kidney function, had risen considerably over the previous 2 years. He had no symptoms, none, felt completely fine, was walking his dog every day, managing his garden. He had no idea. When we went through his medications and habits, it came out that he'd been taking ibuprofen nearly daily for about 18 months for knee osteoarthritis. 2, sometimes 3 tablets a day. No one had told him not to. It was over the counter. It was helping. Why would he stop? That's the story I've seen variations of more times than I want to count. And the insidious part, the part that makes this so dangerous, is that the kidneys are remarkably silent organs. I know I said I'd avoid that kind of language. Let me rephrase. The kidneys don't give you warning signs until the damage is substantial. You don't feel kidney scarring. There's no pain in the kidneys, no obvious signal. By the time you notice symptoms, swelling in the legs, fatigue, changes in urination, you've often already lost significant function. The blood tests will catch it earlier, which is why regular kidney function panels matter enormously after 65. But most people aren't connecting their ibuprofen use to those numbers. Let me give you some numbers because I think they're worth knowing. Studies looking at NSAID use in older adults have found that regular ibuprofen use, defined as more than 3 times per week, increases the risk of acute kidney injury in adults over 65 by somewhere between 50 and 80% compared to non-users. That's not a small signal. That's not a marginal risk. An acute kidney injury, even when it appears to resolve, often leaves behind exactly that residual scarring I've been describing. The kidney bounces back on the surface. Your creatinine looks better, your doctor says you're fine, but the underlying tissue architecture has changed. There's also a specific condition called analgesic nephropathy, kidney damage directly caused by long-term painkiller use. NSAIDs, including ibuprofen, are one of the leading causes. It's not a rare diagnosis. It's something nephrologists, kidney specialists, see regularly. And the patients who end up in their offices are often the same patients who were told for years that ibuprofen was the safe option, the over-the-counter option, the non-addictive option. Now I want to address something because I know what some of you are thinking. You're thinking, but I've been taking it for years and my kidneys are fine. And you might be right. I genuinely don't want to cause unnecessary panic. Not everyone who takes ibuprofen will develop significant kidney damage. Genetics play a role. Baseline hydration plays a role. Whether you have diabetes or hypertension, both of which independently affect kidney function, plays a role. How often you take it and at what dose plays a role. But here's my honest clinical position after years of watching this. The risk to benefit calculation for ibuprofen specifically in adults over 65 with joint pain has shifted dramatically. When I was trained, ibuprofen was the go-to. Effective, fast-acting, well understood. But the data we have now, combined with what we understand about aging kidneys, means I cannot in good conscience recommend it for regular use in this age group. Not when there are alternatives that work. Let me also mention the stomach briefly because people focus so much on the kidneys, and they should, but ibuprofen is also destructive to the stomach lining. It blocks the same prostaglandins that help maintain the protective mucus layer in the stomach. Older adults are already more susceptible to GI bleeds, stomach ulcers, and the complications from those. Combine that with the kidney risk, and you start to see why the risk profile looks so different at 65 than at 35. And then there's the heart. There's data, not new data, this has been building for about 15 years, showing that regular NSAID use increases cardiovascular risk. Blood pressure goes up. There's increased risk of fluid retention, which strains the heart. In someone who already has hypertension or heart disease, which describes a significant portion of people over 65, this isn't a theoretical risk, it's a real one. Okay, I want to pivot now. Because I said I wasn't going to leave you without alternatives, and I mean that. Telling you to stop something without offering something else would be bad medicine. So let me tell you what I actually recommend now to patients with joint pain, osteoarthritis, general inflammation, that kind of chronic low-grade daily pain that ibuprofen was supposedly solving. The first thing I want to talk about is Boswellia, Boswellia serrata. It's an extract from the resin of the Boswellia tree, sometimes called Indian frankincense, and it has a genuinely well-studied anti-inflammatory mechanism. Not folk remedy territory, actual pharmacological research. Here's how it works. Boswellia inhibits an enzyme called 5-lipoxygenase, 5-LOX, which is involved in producing a class of inflammatory compounds called leukotrienes. Now, ibuprofen works on the COX pathway, Boswellia works on the LOX pathway, completely different mechanism. And critically, no effect on kidney blood flow, no prostaglandin disruption, no constriction of renal vasculature. It can do its anti-inflammatory work without touching the system that makes ibuprofen so dangerous. The clinical studies on Boswellia for osteoarthritis are genuinely encouraging. There was a randomized controlled trial published in the journal Phytomedicine. I'm not going to walk you through the entire methodology, but the findings showed meaningful reduction in pain scores and improvement in physical function in patients with knee osteoarthritis taking Boswellia extract over 90 days. Compared to placebo, not just people reporting it felt nice, actual measured outcomes. Other studies have shown similar results: reduced joint swelling, improved range of motion. The effect is not as fast as ibuprofen. This is important to be honest about. Ibuprofen works in about an hour. Boswellia builds up over weeks. You're looking at 4 to 8 weeks before you feel the full effect. That's a real difference, and some patients find it frustrating. But the trade-off is that you're not slowly scarring your kidneys. The typical dose used in most of the studies is somewhere in the range of 100 to 250 milligrams of the standardized extract taken 2 to 3 times daily. I'd always say talk to your own doctor before starting anything because individual circumstances vary, but Boswellia has a very favorable safety profile, particularly compared to what we've just been discussing. Now, tart cherry juice. I know how that sounds. I've had patients look at me like I've just suggested they rub crystals on their knees. Bear with me. Tart cherries, Montmorency cherries specifically, contain very high concentrations of anthocyanins and other polyphenols that have documented anti-inflammatory and antioxidant effects. The research base here is smaller than for Boswellia, but it's real and it's growing. A study out of Oregon Health and Science University looked at marathon runners. Not directly relevant to our population, I know, but hear the mechanism, who drank tart cherry juice before and after a race. Their markers of inflammation and muscle damage were significantly lower than the placebo group. More relevant to joint pain, there are studies looking specifically at osteoarthritis patients showing reductions in inflammatory markers after regular tart cherry consumption. The compound that seems to do most of the work is cyanidin-3-glucoside, which inhibits COX enzymes. Yes, the same pathway as ibuprofen, but at concentrations that don't disrupt the kidney's prostaglandin-regulated blood flow to the same degree. It also has uric acid lowering effects, which is worth mentioning if any of you deal with gout. Tart cherry has actually been shown to reduce gout flares in some studies. Just a side note. The practical protocol I've settled on, and this isn't a formal clinical protocol, this is what I found useful in practice, is about 8 to 10 ounces of tart cherry juice, ideally unsweetened or low sugar, twice a day, morning and evening, combined with a Boswellia supplement. Give it 6 to 8 weeks. Most people who stay consistent see a meaningful reduction in their baseline joint pain. Not complete elimination. I'm not promising miracles, but meaningful. There's also omega-3 fatty acids. I'm going to mention them briefly because they deserve mention. Fish oil, proper fish oil with high EPA and DHA content, has solid anti-inflammatory evidence behind it. Multiple meta-analyses. The mechanism is well understood. EPA and DHA compete with arachidonic acid, which is a precursor to pro-inflammatory prostaglandins and leukotrienes. More EPA and DHA in your cell membranes means less inflammatory signaling overall. For joint pain specifically, the data is strongest for rheumatoid arthritis, but there's supporting evidence for osteoarthritis as well. Dose matters enormously with fish oil. You need at least 2 to 3 grams of combined EPA and DHA per day to see anti-inflammatory effects. Most capsules on the shelf contain 300 milligrams combined, so you're looking at 6 to 10 capsules of standard fish oil, or you buy a higher concentration product. This is another reason people don't notice fish oil working. They're taking 2 capsules and calling it a try. I want to pause here for a second, because I'm aware we're heading toward the part of the video where I talk about alternatives, and I want to be honest with you about something. None of these alternatives are as fast as ibuprofen. Ibuprofen works quickly, reliably, and it feels decisive. You take it, the pain goes down, you feel like it did something. The alternatives I'm describing are more gradual, more like You notice one day that your knees have been better this week. You realize you've been sleeping more comfortably. It's less dramatic, and some of you will try them and feel like they're not working because you're comparing them to the immediate hit of ibuprofen. I want you to hold that comparison loosely, because the question isn't just which one relieves pain faster today. The question is, which approach will let you remain functional with your kidneys intact at 75 and 80? And framed that way, the slower approach is worth it. Actually, while we're on the topic of what to expect over time, and I'll touch on this more in the next video I'm putting out, which covers what actually happens to kidney function by decade and what your blood tests are really telling you. If you're watching this channel and you haven't subscribed yet, you might want to do that now. I cover a lot of material that your doctor doesn't always have 20 minutes to explain in an appointment. Okay, back to ibuprofen, because there's another thing I haven't mentioned yet that I think is important. Drug interactions. If you are over 65 and managing multiple health conditions, which most people are, there is an extremely high probability that you are on medications that interact badly with ibuprofen. Let's go through the main ones. Blood thinners, warfarin, aspirin, newer anticoagulants like rivaroxaban or apixaban. Ibuprofen increases bleeding risk when combined with these. Not a small increase, a real increase. If you're on blood thinners for atrial fibrillation, for a history of clots, for anything, ibuprofen is something you need to discuss carefully with your prescribing doctor before taking even once. ACE inhibitors and ARBs. These are among the most commonly prescribed blood pressure medications. Lisinopril, Ramipril, Losartan, Valsartan. Any of those names sound familiar? Ibuprofen directly reduces their effectiveness. And worse, the combination of ibuprofen with ACE inhibitors is what's called a triple whammy risk when you also add a diuretic, which many hypertensive patients are on. The combination of all three can cause acute kidney failure. There's actually literature on this specific drug interaction. It's not obscure, but it's also not something every patient gets warned about when they pick up ibuprofen off a pharmacy shelf. Diuretics alone, furosemide, hydrochlorothiazide, ibuprofen blunts their effect. You might be taking a water pill to manage fluid retention or blood pressure, and your ibuprofen is working against it every time you take it. Methotrexate, which some people take for rheumatoid arthritis. Ibuprofen increases methotrexate toxicity. This is a serious interaction. I'm not listing these to terrify you. I'm listing them because I want you to see that the risk isn't just the direct kidney mechanism I described earlier. There's a whole web of interactions that makes ibuprofen specifically problematic in older adults who are appropriately managing multiple conditions with multiple medications. And still, it's available over the counter. You can buy it next to the chewing gum at a petrol station. There's a real mismatch between how casually available this drug is and how carefully it should be used in this population. Let me talk for a moment about what your kidneys are actually telling you, or rather, what they're not telling you, and what to ask for at your next appointment. Kidney function is most commonly assessed in blood tests using two markers, creatinine and eGFR. eGFR stands for estimated glomerular filtration rate. It's essentially a calculation of how well your kidneys are filtering, derived from your creatinine level, age, sex, and body size. An eGFR above 60 is generally considered normal. Between 45 and 60 indicates mildly to moderately reduced function. Below 45 starts to become concerning. Below 30 is significantly reduced. Here's what I want you to take away. First, ask your doctor what your eGFR actually is. Don't just accept your kidneys are fine. Ask for the number, write it down, compare it at your next test. Trends over time matter enormously. A eGFR that's slowly declining over 2 or 3 years, even if it's still in the normal range, is a signal worth taking seriously. Second, understand that creatinine can be misleading in older adults. Because muscle mass decreases with age, creatinine, which is a breakdown product of muscle, can be artificially low, which means your kidney function might look better on paper than it actually is. There are more sensitive markers. Cystatin C is one that's gaining traction, but they're not always ordered routinely. You may need to specifically ask. Third, if you have been taking ibuprofen regularly for more than a few months and you haven't had kidney function checked recently, Please get that done soon. Not because I want to alarm you, but because if there is early damage, stopping now and making changes now can slow or halt the progression. You can't reverse the scars that are already there, but you can absolutely prevent more from forming. Here's something else worth knowing. Hydration matters more than most people realize in the context of kidney health, and NSAIDs plus dehydration is a particularly bad combination. Older adults have a reduced thirst response. The body's signal to drink water becomes less reliable with age. So many people over 65 are chronically mildly dehydrated without knowing it. On a day when you're not well hydrated, taking ibuprofen hits harder on the kidneys because the blood pressure within the renal blood vessels is already slightly lower. Add the vasoconstriction effect of ibuprofen on top of that, and the risk spikes. I tell patients, if you are ever in a situation where you feel you absolutely must take an NSAID, genuinely no other option, severe acute pain, drink a full large glass of water before and after. It doesn't eliminate the risk, but it reduces it somewhat. And don't take it when you're sick with a fever or a vomiting illness, when you're already dehydrated. That's when acute kidney injury from NSAIDs most commonly happens. What about acetaminophen, paracetamol? I'll address this because people often ask. Acetaminophen does not have the same kidney mechanism as ibuprofen. It doesn't block prostaglandins in the same way. It doesn't constrict renal blood vessels. For that reason, it is generally safer for the kidneys than ibuprofen and is often preferred for older adults with joint pain. The British and American Geriatric Society guidelines both suggest acetaminophen as a first-line option for osteoarthritis pain in older adults, specifically for this reason. However, and this is important, acetaminophen is hard on the liver, especially at higher doses or in people who drink alcohol regularly. The maximum daily dose should not exceed 3 grams in older adults, and some guidelines say 2 grams if you have any liver concerns. It's not without risk, it's just a different risk profile, and it's better for the kidneys. Topical NSAIDs are another option worth mentioning. Diclofenac gel, for example. When you apply an anti-inflammatory directly to the skin over an affected joint, the systemic absorption, the amount that gets into your bloodstream and reaches your kidneys, is dramatically lower than when you swallow a tablet. The local effect can still be meaningful for joint pain. This is why topical preparations are often recommended for older adults. You get some of the pain relief with a fraction of the systemic risk. Not zero risk, but substantially less. I want to spend a moment on something that doesn't get discussed enough: the role of movement. I know, you have joint pain because movement is difficult. I'm not suggesting you ignore pain and force yourself through it, but there's a phenomenon in osteoarthritis specifically where the synovial fluid, the lubricating fluid in the joint, actually requires movement to circulate properly. Joints that don't move become stiffer, lose cartilage faster, and hurt more. There's a slightly cruel irony to it. The pain makes you want to move less, and moving less makes the pain worse. Low-impact movement, swimming, cycling, gentle walking, water aerobics, helps maintain joint fluid circulation, strengthens the muscles that support the joint and takes some of the load off the cartilage, and has documented anti-inflammatory effects through its own mechanisms. I've seen patients who reduce their reliance on pain medication significantly just through getting into a regular pool therapy program. Not all of them, not dramatically every time, but enough times that I always bring it up. The combination I found most useful for chronic joint pain in this age group is Boswellia supplement, daily tart cherry juice, adequate omega-3 intake, regular low-impact movement, and close attention to anti-inflammatory dietary patterns, which broadly means less processed food, less refined sugar, more vegetables, more fatty fish. Not a miracle protocol, just removing the inputs that drive inflammation and adding the inputs that reduce it. It works slowly, but it works. And it does not destroy your kidneys. Let me also mention briefly that if joint pain is genuinely severe and impacting quality of life, there are other medical options that your doctor can discuss with you. that are far safer than daily oral ibuprofen. Hyaluronic acid injections, corticosteroid injections, platelet-rich plasma. These have their own risk profiles and aren't right for everyone, but they're worth discussing with a rheumatologist or orthopedic specialist. The point is that daily ibuprofen is not your only option. It never was. I think what frustrates me most about this issue, and I don't often say this in videos, but I'll say it here, is that the ibuprofen problem in older adults is not new information in medicine. The data has been there for years. The guidelines have shifted. Geriatric medicine societies have been saying for well over a decade that NSAIDs should be used with extreme caution in adults over 65 and avoided, if possible, for regular use. And yet the disconnect between that guidance and what happens in everyday practice, in pharmacies, in rushed GP appointments, is enormous. Part of it is that the alternatives require more explanation. Boswellia isn't a one-sentence recommendation. Tart cherry juice sounds strange. Omega-3 dosing is complicated. It's easier to say, take ibuprofen as needed and move on. I understand the time pressures. I've worked in systems where you have 7 minutes per patient. I know it's not always a failure of caring, but I also think patients deserve to know this information. That's why I'm here. That's why this video is nearly 20 minutes long instead of 3. Before I wrap up, let me ask you something, and I genuinely want you to think about it and leave your answer in the comments below. Have you ever been told by a doctor, not just a pharmacist, an actual physician, that ibuprofen could damage your kidneys? That at your age, regular use carries real risks? Not just a vague warning, but an actual explanation of the mechanism? I ask because I have a feeling the answer for most of you is no. And that tells me something about where the gaps are. Your answers help me understand what to cover next, so please do reply if you're willing. There's something else I want to say before we close. Some of you watching this are caring for an older parent, or you're helping a spouse manage their medications. This information matters for you too. If someone you love is over 65 and taking ibuprofen regularly, especially if they're also on blood pressure medication, if they're on blood thinners, if they have diabetes, please have this conversation with them. Show them this video if it's easier than explaining it yourself. It might be one of the more useful things you do this week. And if you're watching this and you're in your 50s, this is still relevant to you. The kidney changes I described begin well before 65. The protective reserve starts declining in your 40s. The risk at 55 is lower than at 70, yes, but the principle is the same. Habitual NSAID use chips away at kidney tissue over time, and the time to think about alternatives is before the damage accumulates, not after. So, if you take ibuprofen regularly, talk to your doctor. Ask about your EGFR. Consider starting Boswellia and tart cherry juice. Give it 8 weeks before you judge whether it's working. Think about topical options for localized joint pain. Drink more water. Move more, gently. That's it. That's the whole message. None of it is complicated, but it matters enormously. I'll be putting out a video soon on what your kidney function numbers actually mean. EGFR, creatinine, the whole picture, broken down clearly so you can actually read your own blood work. If that's useful to you, you might want to subscribe so you don't miss it. No pressure, just if this kind of information is helpful, there's more coming. I'm Dr. Whitfield. Thank you for spending this time with me. Take care of your kidneys. They're quieter than your knees, and they matter a great deal more. This video is for informational purposes only and does not replace professional medical advice. Please consult your own doctor before making any changes to your medications or supplements.